Hey everybody. So I've got a lot to cover here and I'm shooting for 10 minutes in preparation for a providers meeting where I'll be giving this information. So let's see if I can do this in 10 minutes. Anyway, I'm so happy to be here and what I'm expecting is a presentation of depression on the clinical side from one of our physicians. And following his excellent presentation, I'd like to offer a little expansion on the documentation part from a CDI and coding perspective. So for anyone who might not know, CDI is clinical documentation integrity or improvement. On the inpatient side, you might recognize that as DRG improvement and clinical validation, but from where we stand on the outpatient side, participating in managed care risk structure, we're looking at the proper documentation for valid and specific capture of chronic diagnosis codes and how it applies to the risk weight assigned to your patients. This excellency in documentation also has a dual effect of providing your documentation for quality measures. So bear with me as I go fast in hopes of covering the full deal here. Depression is a costly diagnosis. Most of the depression codes do contribute to your risk, but non-specific depression codes like F32.A or the old F32.9 do not. Depression's complexity requires precise documentation. Details about severity, recurrence, and associated symptoms are critical for accurate risk adjustment and patient management. Documentation must be provided. Coders cannot assume diagnoses exist based on medication lists or physician orders. All conditions that coexist at the time of the encounter and that require or affect patient care, treatment, or management should be documented and coded. Coders cannot code current conditions from problem lists, medical history, or super bills. Coders must verify clinical documentation for all diagnoses using the MEET tool, monitor, evaluate, assess, treat. One or more MEET details is required for each condition requiring or affecting patient care. So that said, all the above applied to the traditional coding scenarios where the coder retrospectively pulls every HCC code out of the relevant existing patient encounters documentation. Our coders are prospectively prepping the charts to help the provider find diagnoses that were previously reported and also others that are suspect for other reasons. Maybe the clinical validation's there, but it hasn't been captured yet. Since the coder cannot diagnose and make this determination, it's up to you as the licensed clinician to dismiss or validate the suspect conditions. Our providers will be doing this with a software extension called Annex or Parking Lot, and it allows the coder to identify and present the suspects, and the provider will decide yes or no or something else. And when they are accepted, they will be dropped into the EHR. I want to elaborate on MEET from the coder's perspective. So the MEET examples we see here validate the diagnosis for the coder. So at the top, we just see the types of documentation that might exist to meet each of these criteria. So I'm going to go ahead and move to the examples. So like for this one, it's documented major depressive disorder, recurrent severe. And the provider says recommend monitoring CBC, CMP, TSH given psychiatric symptoms. So based on this documentation, the coder knows that this condition was monitored. The next one, it says patient presents with persistent feelings of sadness and hopelessness. So based on that, we know that, this is an evaluation. So we have the E in MEET, evaluate. This one, symptoms are stable, no new concerns, so the provider has made their assessment. And also I want to note in this one, symptoms are stable, they've changed the diagnosis to in remission. So that's something important to remember when coding depression, is that those remission codes do exist. And then for treat, we have increased Paxil to 50 milligrams per day, continue therapy. So coder sees this, we know that treatment has occurred. And any of those things can validate that diagnosis. Okay, so let's look at an example. Looking at the reason for visit, patient is here today for medication recheck. So that reason for visit is clearly documented. You can go ahead and read through the assessment and plan, but basically what we see there is good documentation. The assessment and plan clearly states the patient has MDD, recurrent and severe without psychotic features. The documentation includes meet details, medication effectiveness, discussion, and counseling referral. So based on all that, the documentation does support major depressive disorder, recurrent, severe, without psychotic features, F33.2. So specificity and documentation not only enhances coding accuracy, but also improves communication among providers and supports comprehensive patient care. And when we talk about tools, I just want you to know I will be providing you with some tools and checklists and things soon. But some of the best practices are to use specific diagnostic terms, update regularly to reflect changes such as in remission or an increase in symptoms. Maybe it's gone from moderate to severe. Some other things, collaborate with your coder advocate or CDEI specialist for just to stay up to date on changes in education. Utilize the templates and checklists for compliance as well. Maybe the PHQ-9 is a tool you might use, or others. Here's another example that illustrates how detailed documentation can ensure proper risk scoring and support better care decisions. Incorporating symptoms and history does add value. So in our scenario, we have worsening depression symptoms with insomnia, and the example of the documentation is MDD moderate, recurrent with insomnia, no psychotic features. The outcome is accurate coding and tailored treatment. Coders and CDIs, basically the role of a coder CDI in improving documentation is that we act as partners in documentation improvement. We support the clinicians by identifying gaps and suggesting refinements to reflect the patient's true clinical status. And to do this, we stay up to date on coding guidelines. The benefit that the clinician receives is improved risk scoring, team communication, and compliance. So using available tools, including templates and coder CDI feedback, can streamline the documentation process and ultimately reduce the burden on clinicians. So we're not trying to increase your burden, we're trying to reduce it. A couple more examples of codes for MDD. Depend on the episode, single, recurrent, and severity, mild, moderate, or severe. So for example, F32.2 is for severe without psychotic features or single episode, while F33.2 is severe without psychotic features, recurrent. Ensure the documentation matches the code selected. And just a quick list of the ICD-10 code updates for mental, behavioral, and neurodevelopmental disorders for 2025. And you can see here that the depression codes are there, the F32s and F33s, and also several associated diagnoses in different code sets. And you can also see the little number at the end of each of these is a risk weight. So every one of these carries a weight. So what do we want to take away? Basically just the accurate documentation benefits not just reimbursement, but also patient outcomes. Collaboration and education are ongoing necessities. We want to specify to the highest level of specificity, update regularly. So make your updates not only to your notes, but your A&P, but also your keep your problem list, your history list, and your med list up to date, and collaborate with your coders and stay informed with the tools and training that are available to you. And thank you all for your attention. Feel free to reach out for further guidance or questions about risk adjustment and CDI practices. I wish you all a wonderful evening, and I look forward to meeting you. My email is on the slide, or you're welcome to chat me up on Teams. Thanks so much. Bye-bye.